Welcome to MEDTALKS Turkey. I'm absolutely thrilled to have you with us today. In this explainer, we're doing something super practical and honestly incredibly useful. We're going to take over 100 essential English dental terms and transform them from a static vocabulary list into a lively, totally memorable clinic simulation. So, whether you're treating international patients, diving into English dental literature, or chatting with colleagues abroad, mastering this specific language, that's your ticket to professional confidence. Let's jump right in.
Okay, so here is our roadmap for today's explainer. First, anatomy and tooth types. Then, tooth surfaces. Third, clinic actions and verbs. And finally, describing the dental environment. Let's get going.
Section 1. Anatomy and tooth types. Mapping the oral territory. Right off the bat, to navigate the mouth with real confidence, you've got to master spatial opposites. Maxillary strictly means the upper teeth, and you'll pair that conceptually with anterior, that's your front teeth. On the flip side of that, mandibular refers to the lower teeth, while posterior groups together all the back teeth. Think of these four directional terms as your absolute clinical compass.
Let's look at the scientific names, starting right at the front and center with our incisors. You've got the central incisors exactly in the middle, and they're flanked by the lateral incisors. Now, as we move back, you'll hear the terms premolars and bicuspids. Good news here. Those are totally interchangeable terms for the two teeth sitting right behind the canines. And finally, sitting all the way in the back, we reach the molars, which are those large, sturdy teeth engineered for heavy chewing.
Now, what's really fun is the incredibly colorful slang native English speakers use in the clinic. Sure, canines or cuspids are the scientifically accurate names for those pointed teeth, but your patients? They'll almost always call them an eye tooth, or even a vampire tooth. It's true. And then, of course, there's the infamous wisdom tooth. That's your third molar. We all know that one frequently causes trouble, or sometimes it's just completely missing altogether.
So the crucial thing here is anchoring your orientation to the midline. You want to think of it as this invisible, vertical axis perfectly dividing those two central incisors. Every single measurement and alignment in modern dentistry, it's all measured right against this imaginary boundary.
Looking at the structures surrounding the teeth, we've got the palate, which is the roof of your mouth, the soft outer lips, and those fleshy cheeks on the side. The tongue, of course, is that strong muscle constantly interacting with the teeth. Holding all of this together is the gingiva, that's the clinical term for the gums, and the strong bone of the jaw, which houses the individual sockets where every single tooth securely sits.
Let's actually slice into the tooth itself, moving from the hard enamel exterior down into those unseen depths. Right beneath the enamel lies the softer dentin. That dentin protects the pulp, which is the really sensitive, living center of the tooth. Inside that pulp is the nerve, and keep in mind that nerve is going to look dark on an X-ray. Now, dropping below the gum line, we find the root, hidden away in the bone, containing the hollow canal, and it all culminates at the apex. That is the absolute tip of the tooth root, buried deep down in the jaw.
In the clinic, during an exam, you're constantly searching for specific findings, right? You might chart a cavity, which scientifically we call dental caries or decay. You're definitely going to spot sticky plaque and hardened calculus or tartar, all bathed in saliva. You've also got to be on high alert for an abscess, which tells you there's a localized infection, or maybe an abnormal tissue lesion. Oh, and don't forget tori. Those are natural bone growths that pop up white on your x-rays. Moving right along to Section 2, Tooth Surfaces. Navigating the 11 directions.
Getting a handle on interproximal, which we often just abbreviate as IPR, is absolutely vital. It describes those tricky, hidden spaces directly in between the adjacent teeth. This is exactly where the dental floss goes, and unfortunately, it is exactly where decay absolutely loves to hide silently.
Let's jump back to that invisible axis we talked about earlier. Notice how mesial always points toward the midline, while distal points away. It's a perfect spatial contrast. Every single tooth in the mouth has a mesial surface leaning to the front and a distal surface leaning toward the back.
Okay, let's break down the inside and outside terminology. Lingual surfaces are on the inside next to the tongue, while palatal refers to the upper inside right next to the roof of the mouth. Facing outward, we use the big umbrella term facial. But if you want to be highly specific, you use labial for the facial surfaces of front teeth that actually touch the lips, and buccal for the back teeth resting right against the cheeks. And to finish up our surface map, we need the terms for the very tops of the teeth. If it's a posterior back tooth, you use occlusal. These surfaces have natural indentations we call grooves. But if we're talking about the super thin, sharp biting edge of an anterior front tooth, that is exclusively called the incisal surface. All right, section 3, clinic actions and verbs, basically what we do.
Every successful appointment follows a really logical flow of actions. It starts from the very first second you ask the patient to open or open wide. From there, you clinically examine their oral cavity. You check to verify the overall health of the tissues and any existing restorations. And ultimately, you use your expertise to diagnose and identify the precise problem.
Now, these next verbs represent the very specific instructions and actions your patient will actually perform while they're sitting in your chair. You'll ask them to bite down, to close their teeth together. You might ask how they chew their food, to crush it with their posteriors. You'll probably ask them to smile to evaluate aesthetics, or see if they can touch a sensitive surface with their tongue. And of course, during and after the procedure, they're going to rinse with water and spit to empty their mouth of liquids.
And here we have the core vocabulary for your hands-on interventions. You inject local anesthesia to numb the patient so they don't feel pain. You might isolate the tooth to keep it completely dry. You'll use your handpiece to drill and remove decay, or maybe even extract a tooth entirely. After that, you fill the cavity and cure it with a light, or you restore the tooth by cementing a permanent crown in place. Finally, you adjust the bite, making minor changes, all while managing any tissues that happen to bleed.
Wrapping up our action words, we instruct patients to floss and brush to clean away plaque. Back in the chair, a hygienist will polish the teeth to make them smooth and shiny. Over on the surgical side, things get a bit more intense. You might sedate a nervous patient with medicine, aspirate to suction fluid, or suture the gums after an extraction. Finally, you'll prescribe medication and rely on your amazing team to sterilize the instruments completely. Let's move into our final section. Section 4, describing the dental environment. These are our clinical adjectives. Mastering these two total opposite words is a real game changer because it allows you to instantly, confidently interpret X-rays. Radiolucent refers to areas that show up distinctly dark on the film. We're talking about things like the nerve canal or active decay where tooth structure is literally missing. Conversely, radiopaque refers to dense, solid structures that actually block the X-ray. These show up stark white or light, like dense bone, tori, or metal fillings. We rely on these vital adjectives to translate exactly what the patient feels into a highly professional clinical record. For example, if a patient describes an intense, sudden burst of pain, we're going to record that as a sharp or acute sensation. We might advise a soft diet that's easy to chew post-surgery. We also need to distinguish between a local issue that's confined to just one area versus a chronic, long-lasting condition. We'll visually note red, inflamed tissues, we'll diagnose teeth that are stuck or impacted beneath the bone, and above all, we ensure all our notes remain highly clinical, scientific, and descriptive. Finally, these modifiers categorize our specialized fields and distinct phases of human dentition. A patient might be sensitive to hot or cold, or they might be entirely asymptomatic with no pain at all. We provide orthodontic care for moving teeth, periodontal care for the gums and bone, and endodontic treatments for the inside nerve. We use pediatric for children. We know congenital conditions that are present from birth. And we track that amazing transition as deciduous baby teeth erupt, serve as temporary placeholders, and eventually give way to permanent adult dentition. So we've just mapped out the essential architecture of English dental terminology. But here's my challenge to you. The next time an international patient sits in your chair, holding their jaw in pain, are you going to freeze? Or will you seamlessly diagnose their acute, radiolucent, interproximal lesion in absolutely perfect English? The vocabulary is all yours now. The real question is, how will you use it to transform your practice tomorrow? Thank you so much for joining me on this explainer. Keep practicing, keep learning, and stay tuned to MEDTALKS Turkey.